Good morning, everyone. It's about 11:35 or maybe 11:36, and the line is now very short, so we do want to get started to be respectful of your time. I am Meg Disler. I'm the director of the St. Joe Community Health Foundation, and delighted to see you all here on this day where we actually have sunshine in Indiana in February, which is wonderful. We're going to start right away with we would like you all to watch a short video about the census. And it will explain it pretty well. I do want to encourage you have materials, but we have these gorgeous posters, a lot of them from the Census Bureau, probably 100 of each of them. I want to encourage you to please consider taking them back and putting them at your workplace or to use them. And afterwards, you'll understand, the video will go into it, how important the census is. One of the things we found is that when you look at who is undercounted, it's families with small children, particularly lower income families. And so you all are going to become critical to help get out the count. So we've got resources for them that fund many of the programs in this room. So with that, we're going to start with a video that'll explain a lot of this.
Kids aren't born with the ability to drive themselves to school, or diagnose themselves when they're sick, or write legislation to protect themselves. Kids depend on adults, their families, communities, and governments to support their health, education, and well-being. And it takes a lot of us working together to help kids and their families have the resources they need. So how are resources for kids and families allocated to our communities? Much depends on the U.S. Census. The Constitution mandates that we count everyone in the country every 10 years, and the 2020 census is closer than you think. Since children can't complete a census form, they rely on us to do right by them to ensure they're counted. An accurate count means communities get the resources they need, like funding for schools, libraries, and healthcare. But right now, there's a risk that more than 2 million children under age 5 may not be counted. That's a mistake we'd have to live with for 10 years, one that would lead to crowded classrooms, underfunded programs, misleading research, and big problems for all of us. The kids most at risk of being missed include children of color and kids in low-income and immigrant families, plus young children from certain rural areas, in multifamily households, and on American Indian reservations. Our kids lose when vital community resources from schools to hospitals dwindle. These resources are critical to the long-term success of all children. The impact of missing millions of kids in the census could be devastating. For kids to count, we need to count all kids in the census. It's up to policymakers, communities, and our nation to do right by our kids. Nationally, we must ensure the 2020 U.S. Census is fully funded and inclusive, while reminding everyone that participating is convenient, safe, and required. On a local level, state, county, and city officials must engage community partners, from nurses and childcare providers to teachers and faith leaders, now to reach hard-to-count households with young kids to encourage participation in the 2020 census. The more accurate the count, the better we can track and understand how our nation's children are faring. And if we don't count children, we make their lives invisible and their futures uncertain. The 2020 census is around the corner. By acting now, we can ensure that we count all kids in the 2020 census. Visit countallkids.org to learn more and take action. The kids in your community are counting on you.
Very quickly, we have given you guys at each of your place settings some different information for you. The goal is to really have you endorse and encourage people how important it is. Probably many of our new families, this will be the first time they've ever been asked to complete the census. It will be online, and I think your ability to support them, help them, maybe do it at your locations, but to make sure that they understand how important it is. There's a great little sheet of paper that gives you checklist, all the different easy roles that you could just do by how you can just support it through your things, including posters, etc. So that's the first thing we ask you to consider doing that. April 1 is the date of the census. So before we meet the next time, we should have the census underway. So we highly encourage you to please support that, because I think for everyone counted, it's somewhere between $1,700 and $2,000 comes back into this region for everybody counted. So it's a great way to influence it. The second thing we want to ask your help on is the state health department is doing a survey, and that they really need everybody to complete the survey, certainly by the area region, and so I think they do track it regionally. So if you've ever had a child, if you work with children, everybody in this room, man or woman, is good to fill out the survey. They just need feedback from the region. When you open it on that link, and you've got an easy QR code here, you can zap if you have that on your phone, and do it that way. It says 15 minutes. I think it took me 5 minutes to do it. It's multiple choice. It's pretty easy. There's places if you want to give a longer feedback and answer, you can do it. But it is a listening, and it'd be great to get good turnout from this region. So that's a second request we have for you. Next, we do want to have a quick presentation by an exciting new program here in this community, and I am looking for, there she is, to turn over the mic. A new program, Engaging Childcares Towards Healthier Moms and Babies. It's Staci, you want to present?
Absolutely. I'm just going to take a couple minutes this morning. I did put a little packet of handouts in the back there for you as well. But yes, you guys will hear more today from Dr. Nancy Swigonski, kind of about the why of this program and what we're looking at, just to look at infant mortality a little bit differently in our community. But in order to do that, there's a couple of different things that we're doing. One is we are partnering with Childcares to first make sure that they have the safe sleep materials they need to actually take care of infants that are in their care. And we also want to make sure that we're supporting them so that they can offer more infant slots. We know that's a huge issue in the community, is having the infant spots available for a lot of those families that need them. And then we also want to be training and talking with those childcare providers to make sure that they know about safe sleep and they know how to share that message with families as well. The other side of that, and something I wanted to provide to you this morning, is also helping families that we serve know what to look for when it comes to high quality childcare. For one of our main partners is the Childcare Resource Network. So I've included two handouts from them that would be really helpful for those of you that are working directly with families. One, to just have that conversation of what does high quality childcare look like with those families and kind of what questions to ask. And that second one is actually the checklist that they can use when they go into a childcare center for the first time, looking at how does the teacher interact with their child? What does the environment look like? What different kind of things should they look for? So again, we're kind of looking at it from two different directions. One, how can we support those childcare centers, but also being a resource to those of us that are working directly with families that need childcare as well, to make sure that they're choosing high quality programs. My business card is on there. If you guys want a PDF version of some of these handouts to use, I'm more than happy to provide some of those or get you connected with the Childcare Resource Network as well. Okay.
I have one question for you. If a lot of the people in this room do home visiting or are working directly with families, if they hear from some family that they have their child, they're not sure about the child care, can they get in touch if that child care needs support? Can they refer that child care to you or get a hold of you? Can you just talk about that? How they can
Yeah, absolutely. Absolutely. That is the other part of our program too. Since we're working directly with Childcares, if you are working with a family that has their child in childcare and they have some concerns, or it would be good for somebody with some safe sleep background as well to be engaged with that childcare, our referral form is on the website. It's also you can just email me directly as well. And as long as I can get the name of the provider, I should usually be able to fill in some of the gaps and make sure that we're engaged with who we need to be engaged with as well. Okay.
I think it's a great resource to help the child care providers get what they need for higher reimbursement. It's not just punitive, but if somebody said, we just don't know how to fill out this form or how to go forward, you all may see some of that. So it's a great resource. So thank you, Staci.
Okay, the last thing, we gave you lots and lots of information in your packets. So this is kind of my passionate one right here. We all know the impact of health and nutrition, right, on our pregnant mothers and fetal development. So the St. Joe Community Health Foundation, in alliance with Parkview Health, has the HEAL program, Healthy Eating, Active Living. Part of that is an 8-session Our Healing Kitchen cooking class. Our grant period opens March 9th. So we give many grants to organizations to hold these cooking classes. We have a lot of organizations that do it now. But I just wanted to make sure if you know of a church or an organization that serves those that are in low income, low access areas that really could benefit from nutrition information and healthy eating, then have them go to our website and look it up.
Laura, can somebody in this room host a class?
Somebody does, Stacy. Yes. Any of your organization, I mean, just look at the grant. We only ask that you have about 8 to 10 people, and the rest is pretty easy. So.
Okay, one of the things we need to do kind of really quickly, but very important, is we want everybody in here to introduce themselves, your organization, and who you're with. If you have a very new program you want to make sure we're aware of, mention it. Otherwise, you could just kind of keep passing it because we have a lot to cover. But we did have found that 85% of you in this room have found it helpful to know who's in the room because it's enabled you to help build referrals, to know who to go to in the room. So we're going to start over here. We do ask you to stand up and just kind of face the room and to use the microphone, please. Say your name and the project you're working on, and then just keep passing it. And if there's something big going on new at your organization.
My name is Courtney Sudak. I do the breastfeeding outreach at Allen, Noble, and DeKalb County WIC office.
I'm Shelby Feaster, and I'm her supervisor at the WIC office.
Amber Ramsey, community health worker from Parkview. We do home visit and provide education for families.
Kai U, community health worker with Parkview Health, and we do home visits and for pregnant moms and babies. And our goal is the infant mortality rate and review.
Takia Arrington with the Women's and Children's Outreach, community health worker.
Maria Diaz, community health worker.
Gwendolyn Carpenter with Parkview Health, safety pin project manager.
Jania Freeman, community health worker with Parkview.
Jessica Flores, community health worker with Parkview.
Janae Moore, community health worker with Parkview. And a Mother's Hope, a resident advisor.
Sorry, I had to out her on that. Stacia Roth, executive director of Mother's Hope.
Renee Hammett, and I'm with Journey Birth and Wellness.
I'm Shanna Bradley. I'm the director of Journey Birth and Wellness, and we support immigrant and refugee families through birth services, through pregnancy, labor, postpartum support, and building community around birth and motherhood.
I'm Renee Cleland, doula with Journey Birth and Wellness.
I'm Kelly Bauman. I'm stewardship with Associated Churches.
I'm Betsy Henderson, site director for A Baby's Closet with Associated Churches.
I am Patience Kaywood, and I'm director of Associated Churches.
Administration.
Hi, I'm Melinda Lauer with Associated Churches. I'm the Director of Communications. We do have a new project coming up, hopefully. It's called the New Mission House, and we're hoping to help with some classes that are going to be more involved with A Baby's Closet.
Good afternoon. I'm Belinda Dean with the Neighborhood Health Clinic Social Services. With the neighborhood, we now have mental health counselors there who are licensed and who are willing to help anyone in need.
Hi, I'm Megan Wilkinson, and I'm on work on curriculum development with Macmillan Health.
Nicole Fairchild with Macmillan Health. I'm the executive director. We develop preventive health education for students from birth through aging adults and curriculum and then media to also go along with that curriculum. And we work with community organizations to develop resources for them.
I'm Mary Luderman with Healthier Moms and Babies. And so we are early prenatal home visiting program in early childhood.
I'm Alicia Katz, and I'm an area coordinator for Young Lives. We're an outreach program to teen moms, and we provide mentoring.
I'm Libby Martin with Lutheran Social Services. I'm over Echo Teen Parenting, our Gear Up for Safety, and our Community Partners programs.
I'm Jamie Martin, Family Engagement Coordinator with Vincent Village, and also Resident Advisor at Mother's Hope.
Hello, I'm Brian White with Give Here.
I'm Amanda Chappell. I'm the Covering Kids and Families Program Manager. I supervise our health insurance navigators in 11 counties here in Northeast Indiana.
I'm Joellen Lekomsky. I'm the Outreach and Enrollment Coordinator with CKF with Brightpoint, and I assist the clients with getting insurance through Medicaid and Marketplace.
Hi, I'm Jody Webster. I'm a nurse navigator up at Parkview, and we've been kind of a different thing. We've been seeing all the newly pregnant, OB patients through their pregnancy, and we're moving into the pediatric world as of about a month ago. So taking referrals from the NICU, taking referrals from kind of all over, but we're hiring some more navigators, so hopefully we can extend our reach a little bit.
My name is Jenna Mitchell. I'm also a maternal child nurse navigator with Parkview, and I work with OB patients.
Stephanie Good with DuPont Hospital, birth navigator, childbirth educator.
Janet Elmer with DuPont Hospital, childbirth educator and prenatal postnatal education.
Maya Pfeffer with Community Harvest Food Bank. I'm the Community Engagement Coordinator.
Mary Carpenter. I'm with Community Harvest Food Bank, and I'm the Director of Operations there.
I'm Corey McKenzie, Community Health Worker at Parkview.
I'm Kirsten Bailey. I'm also a community health worker with Parkview.
Hi, I'm Carla Harrison. I'm a community health worker, and I also train the community from Health Visions.
Good morning, everyone. My name is Renetta Williams, and I'm the Director of Health Visions of Fort Wayne, and we are the organization that train all of these wonderful community health workers. So welcome.
Hi, I'm Lanissa Maggart. I'm our Family Services Manager at Early Childhood Alliance.
Erin Norton, Parkview, Women's and Children's.
Hi, I'm Leanne Pritchard. I'm the Director of Nursing at a Hope Center.
I'm Kathy Wilson, Director of Development at a Hope Center, and we have a new open house tonight at our Hobson Road address, 3630 Hobson Road, 5:30 to 7:30, if you want to hear more about a Hope Center and what we do.
Hi, I'm Teresa Barker with the Hope Center, and I'm the Center Director at Hobson Road.
I'm Joe Faulkner, and I'm the Executive Director of all these wonderful people at Hope Center.
Hi, I'm Sarah Schneider. I work at Parkview, but I'm actually here as part of a student program with my WGU program.
Cindy Coyne, same situation as Sarah, just kind of.
Alice Kupfer, St. Joe Community Health Foundation board member.
Ann Keel, I'm director of the Women's Care Centers in Fort Wayne. There's too many health things going on.
I'm Mary Friend. I'm the mental health counselor for the YWCA's Domestic Violence Services.
I'm Trish Wingo, and I'm an intern at the YWCA.
I'm Christy Geiger, and I am the Executive Director for the March of Dimes for Indiana.
I'm Heather Henry with Parkview's Community Nursing.
I'm Brittany Ely, and I'm a community health worker at Parkview Health.
I'm Sharon Tubbs. I'm with the St. Joe Community Health Foundation. I'm their community liaison. And we are doing a new PIC newsletter every quarter. And so I would ask you if you announced or would like to have your new program announced in the newsletter, where we'll just say what the new program is very briefly. If you could stop by this table and talk to me afterward, or if you have a flyer, give that flyer to me. I know someone over there was talking about a new program at Associated Churches, and I didn't even hear what you were saying. So if you could let me know what that is and send me that information, and I'll give you my email, then that would be great. Yay!
I'm Lori Newman with the Fort Wayne Christ Child Society.
Tina Bailey, the president of the Christ Child Society in Fort Wayne.
I'm Sarah LeBlanc. I'm with Purdue University, Fort Wayne. I'm an assistant professor of interpersonal family and health communication who studies postpartum depression within mothers. Also, PFW Department of Communication is launching this fall a post-BA certificate in health communication. We have information available on our website, or you're welcome to send me an email and I can send it to you.
I'm Rachel Mitchell. I'm with Purdue Fort Wayne, and I study communication and women-centered care.
My name is also Rachel. My name is Rachel Joseph, and I'm with the Shepherd's Hand Community Outreach Center. The biggest new thing that we have going on is that we're working to network with more partners interested in working with us as we establish a diaper bank for our health resource fairs. So some of you I've already been in touch with about that.
I'm Laura Dwyer, St. Joe Community Health Foundation.
Marlene Krause, Health Coordinator, Bright Point Early Head Start.
Good afternoon. I'm Betty Canavati. I'm here under several different hats. I'm the editor of the Fort Wayne Medicine Magazine, and so I'm always interested in what our nonprofits are doing here in town. And like you, if you have a new program, if you send any information to the Fort Wayne Medical Society, we may be able to highlight your organization in one of our quarterly magazines. I am also representative of the Indiana State Medical Association Alliance. We, in November, started an infant mortality initiative around the state. We're doing baby showers at the IU Schools of Medicine, and we did one here in November and co-partnered with Healthier Moms and Babies and donated some money for cribs and safe sleep packs. And we've also done one in Indianapolis and one down in Evansville. And our next baby shower is going to be in Terre Haute with infant mortality as a theme. And as a member of the Fort Wayne Medical Society Alliance, I just kind of wear vague hats. I'm a past president, and we have an upcoming Doctor's Day at Science Central. We rent the building for the whole day. It's Saturday, March 7th. And anybody can come. We hope that it's geared for young children. We send flyers out to the elementary schools in Fort Wayne. And so if you're working with any of your patient populations and you can pass that word out, they can come, the whole family can come. It's a free event. It's really a lot of fun. And we do this as a community service project of the local alliance. Thanks.
Hi, my name is Michelle DeArmond. I'm with Lutheran Hospital and run our Mood Changes in Moms program. And this is my daughter.
And we have a baby in the room.
Oh, wonderful. Well, we're going to change the agenda order just briefly, and I'm going to give the world's shortest introduction to Dr. Nancy Swigonski. You did see her write-up in the invitation that came out, but I truly think she is a gem, a hidden gem in the state of Indiana, and has a lot of great information. So, Nancy, I'm going to just turn it over to you.
Perfect. Thanks. Thank you all for inviting me to come. I was here before actually talking about early brain development, and infant mortality is an interesting way to bring those two topics that are near and dear to my heart. So we're going to go through things very quickly. One of the things that's going to happen is Erin's going to talk afterwards and lead you all in a thought process or discussion. So I have 4 objectives. One is to identify the most preventable cause of infant mortality, identify the need for interconception care, and many of you in this room are already doing that, so it's awesome to hear. Recognize racial and geographic disparities. And then what I really want you to think about is the 3 frameworks that we think about that overlap and interdigitate and may give you new ways to think about your programs and maybe what should you be doing next, or how can you partner with somebody to do something that is a little bit to make the sum of the parts greater than the whole greater than the sum of the parts. So those 3 frameworks are life course, social ecologic model, and the social determinants of health. So you guys all know infant mortality is the death of a baby before their first birthday. You may not know that there's twice as many deaths in the first year of life as the next 13 years combined. And I'm going to remind you of this last statement towards the end of the talk. It is a leading indicator of health and social stability. So I always tell people, guess what agency in the federal government actually tracks infant mortality throughout the world? The CIA, because it is an indicator of social stability. And we don't think of it like that, but I think it should change the way you think about how you're working with families. So let's talk about Indiana's infant mortality. So in 2017, 602 deaths. We did a little bit better for this past year. Just to remind people, we have 2018 data because babies have to live to be through 2019. If they're born in December, they have to live till December 2019, right, to show that they didn't die within that first year of life. So we basically are 6 weeks into when we could have new data, and the new data will be coming out shortly. But for the most part, I have 2017 data, not the details of the 2018 data. And when we get that, I'm sure that Meg and others will share that with you. So that means in Indiana, 1 baby dies on average every 16 hours. And the way I always state it is by the time you wake up tomorrow morning, on average, another baby in Indiana will have died. That's 1 to 2 babies every day. So this is where we were in 2005. Indiana was sort of in the lower middle of the pack of states in terms of infant mortality. And guess what? We're now one of the worst states in terms of infant mortality. So we are not making good progress. Another way to look at this is just a graph. The top line is Indiana's infant mortality. And the good news is the past 2 years, it's actually dropped. So the 6.8 is the same as 2012 or 6 years ago, and the same as 10 years ago. But in general, what I did to show the trend is to draw trend lines. Basically, it's a regression analysis through these to say how well are we doing. And the next thing I do actually is remove the numbers and data points so you can just look at the trend lines. And what I want you to notice is here was the difference between us and the rest of the United States over 10 years ago. And guess what? That gap is widening. The rest of the United States is doing a little bit better than us in terms of improving our infant mortality. So this recent news is really good news, but we've been there before, and we have to continue that work. So what is the star here? That is, in fact, the best state in the nation. In 2017, they had half the infant mortality of Indiana. Now, how can that be? That one of the states has half of the infant mortality rate than we do. So anybody want to guess which state it is? You got it. It's Massachusetts. All right. So let's talk about Allen County. And again, these are 2017 data. There were 38 babies that died in 2017. And it's always interesting to me to talk about infant mortality because, you know, if you just talk to a legislator or somebody who doesn't really kind of get it, 38 doesn't sound like a lot. But if you say that's 1 baby every 9 days, in your county that dies. 3 babies a month. That's not okay. All right, so let's talk about the causes. This is the way the CDC divides the causes. About half of it is what's called perinatal risk. About 1 in 6 is SUIDs, or sudden unexpected death, and we'll talk a little bit more about that. About 1/5 is congenital anomalies. There's a bunch of other things that fall in there as well. I and many others don't find this is a really great way to look at infant mortality in terms of prevention, right? What can we do to prevent infant mortality? This categorizes it after it happened. So there's something called perinatal periods of risk that was developed by City Match and by the CDC. And it looks at infant mortality from an epidemiologic perspective, right? What are the causes that might be prevented, and how do we start to look at those? And what they do is divide by weight. So if a baby's less than 1,500 grams or greater than 1,500 grams, and for people who work in these areas, you know that for some magical reason, 1,500 grams is a pretty strong biologic cutoff in terms of outcomes. And then they look at fetal deaths, they look at neonatal deaths, and then post-neonatal deaths. And basically, if the baby's born less than 1,500 grams, the idea is really that baby needs to stay in the incubator, right? If you're born less than 1,500 grams, the best thing that we can do for you is keep you in your mom's womb. So what can we do to help do that? If there's a fetal death, but the baby weighs more than 1,500 grams, that's really about maternal care. Did we do kick counts? Did the mom have prenatal care where they looked at the growth of the baby and looked at the heart rate? If the baby died between 0 and 27 days, that's really about newborn or NICU care, right? And if the baby died after 28 days, that's about infant health. So when you look at it, again, epidemiologically, maternal health and prematurity, you really need to address things like chronic disease, health behaviors, and perinatal or interconception care. If really where you're having the most deaths is related to maternal care, you really need to focus on prenatal care, high-risk referrals, etc. If you're having the most deaths in newborn care, it should be about perinatal management. And if it's infant health, you should really focus on these things. Now, the reality is we know most babies are going to die here, right? And so epidemiologically, they did something else that was very sophisticated. And what they said is, we're going to take a standard group that is low risk in wherever the community is that you are. So that low risk group is white women with at least a year of college education between the ages of like 20 and 32. Don't quote me on the ages, I always mess them up. But that's a low risk group. So if their infant mortality is here, let's compare it to everybody else, okay? That difference between the low-risk group and everybody else is called the excess mortality. There's no reason biologically why we can't bring everybody else down to the level of that standard group, okay? Theoretically, the excess mortality is where you should be able to make the difference. Does that make sense to everybody? Okay. So where do we see that excess mortality? What we see is and this is from Marion County, and I put this in because they just finished this analysis like a couple of months ago. So I'm including this one. But basically, 2/3 of their excess mortality is in maternal health. About 9% is in maternal care or OB care, 5% is in newborn care, and about 24% is in infant care. So let me remind people, that does not mean these aren't important. They are, because most babies will end up dying, right, as premature babies in newborn care. But what it says is regardless of your race, ethnicity, age, insurance level, right? That there isn't excess mortality in that newborn care. So to move the needle, we would have to move all of newborn care. In these other areas where there's lots of excess mortality, that should be the low-hanging fruit. If other people can get there, why can't we get everybody there? All right. So this is Indiana, but it's old data. It's from 2011. But again, seems to be a consistent pattern in places that have high infant mortality, is that a good portion of it is maternal health and a good portion of it is infant care. So again, if we want to attack infant mortality in our state, you need to really be thinking about and working in maternal health and infant health. Not just, again, very important, these things are important, but if you're only focusing there, I don't think that we're going to make the progress, and frankly, we haven't made the progress that we want to make. All right, so let's talk a little bit about maternal health. This is our preterm birth rate. It's pretty consistent with the United States overall, but it really, when you look at it, it's pretty flat. So at least, excuse me, in the past 10 years or so, we haven't made big differences. And the interesting thing is if you look nationally, the preterm birth rate is actually on the rise. And in Indiana in 2018, it also went up, and we're not really sure why. Let's talk a little bit about maternal health. So the Secretary's Advisory Committee on Infant Mortality basically said when we talk about infant mortality, we really need to think about life course. And this is the first framework that I've asked you all to really think about when thinking about your programs, what else you guys might do, who you might connect with in your community, is to think through life course. If you're in one area like prenatal care or birth, how are you going to connect to these areas of preconception and interconception care? So if you look at preconception care, again, care consistent with your reproductive life plan, family planning, immunizations, folic acid, don't expose to teratogens, no alcohol, I should say no alcohol, alcohol management, screening for infectious disease. This didn't show up well, but it comes clear across here. Maintaining healthy weight, smoking cessation, chronic disease control, psychosocial supports, screening for behavioral and mental health. So again, a lot of these things I've heard in your community, but if you really want to impact maternal health and therefore the excess mortality and infant mortality, listen to the people in the room and think about how you are working with them to do some of these things. So I'm going to focus a little bit on preconception and interconception care. In 2015, the American Academy of Family Physicians actually came out and said pre- and interconception care is primary care. Before, we've always said, oh yeah, the OBs will do that, right? OBs are also primary care providers. And so even though this doesn't sound like a dramatic statement, at that point in time it was, because they said, no, family medicine, you really need to focus on this as well, because we need to have healthy moms. So they actually recommended the incorporation of preconception and interconception care for all routine care of people who are being seen in primary care. So how might this be done in other areas in thinking about interconception care? So one of my colleagues, Emily Scott, who actually is the vice president of the Indiana chapter of the American Academy of Pediatrics and will be president in May, is doing something called Implicit with primary care pediatric practices. And what this does is we know that the care for women of childbearing age, we have to focus on her and the health of her current children and her future babies. We know that, as we talked about, poor birth outcomes require interventions and risk reduction before pregnancy. And even more important, it's even more important in women who have had previous birth outcomes. So only 18% of women get preconception care. In general, women of reproductive age is declining. 50% of the women are overweight or obese, 19% smoke, 10% have hypertension, and 3% have pregestational diabetes. That is not a healthy recipe for a healthy baby. And half of pregnancies in the U.S. are unintended, with low-income women having 5 times the rate of unintended pregnancies. So the other thing that we see is after the baby's born, women really get fragmented care. And generally, moms take over a year to reestablish their own health care. So they may, during that time, revert to things like smoking and substance abuse that many have, in fact, stopped during the pregnancy. So even though a mom doesn't have her own primary care provider, most moms do take their babies for well child care. So how, again, thinking beyond what we usually do, can we do something different to address infant mortality and that excess mortality? And again, what Implicit does is during a well child care visit, the pediatrician also screens the mom for smoking, depression, family planning, and multivitamin folic acid use. How can we care for moms? So generally uses the 5 A's model, which is ask, advise, assess, assist and arrange, and then analyze. So collect your data to make sure that you're doing what you think you're doing. So we know the first one really is smoking. And so we know that tobacco use during pregnancy is associated with chorioamnitis and incompetent cervix, placental abruption, pregnancy-induced hypertension, congenital anomalies. It's associated with 5 to 8% of preterm births, 13 to 19% of babies that are born with intrauterine growth restrictions, and a high percentage of babies that die from SIDS, as well as long-term consequences like childhood obesity and metabolic syndrome. For every $1 spent on smoking cessation, $3 can actually be saved in NICU costs. Half of women stop smoking in pregnancy, but 70 to 80% relapse post-term. We need to support moms after the baby's here. Maternal depression. 1 in 7 women is affected by perinatal depression, and it peaks about 6 weeks after birth. Minor depression really peaks at 2 to 3 months after birth, with a second peak we often forget about at 6 months of age. So 400,000 infants are born each year to depressed moms, and this depression is highly, highly treatable. So children of moms who are depressed are at an increased risk for low birth weight or preterm, at an increased risk of developmental delay with lifelong consequences at 18 months, and also at increased risk for physical health problems during childhood. What about healthy pregnancy spacing? We know that if you have babies at least 18 months between pregnancies, you're more likely to have a healthy baby. Women with these pregnancies are more likely to be nutritionally fit, to engage in healthy behaviors, and to actually attend prenatal care. And they're less likely to have preterm birth. Every $1 invested in helping families plan and space their pregnancies actually saves taxpayers almost $4 in pregnancy-related costs. Obviously, there's a lot of different mechanisms to help families and talk through what they would choose in terms of planning, or if they say, I don't want to plan, that's okay. Are they taking prenatal vitamins? Are they doing other things to make sure that they have the healthiest pregnancy ever? But we do need to help families think through what they're doing so they can have healthy pregnancies. So want to mention long-acting reversible contraception because there's some really good data now on it, including that it helps increase the spacing, prevent unintended pregnancy, It is the most effective form of reversible birth control, 20 times more effective than birth control pills, has the highest patient satisfaction rates, and there's actually good studies to show it reduces unintended pregnancies and, in fact, reduces abortions. What about folic acid? Folic acid supplementation is needed by 4 weeks after conception when most women don't even know they're pregnant. 70% of U.S. women do not take a multivitamin or folic acid supplementation in the month before they get pregnant like it's recommended. So multivitamins reduce the risk of neural tube defects by 72%. And I heard lots of stuff about nutrition and helping with cooking and linking. Really important. Even when they do that, they should take supplementation with folic acid. So the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of OBGYN also all recommend that interconception folic acid or multivitamin supplementation. So let's talk about, we talked here about one of the major causes, which we really link to maternal health more than anything else. Let's talk about this cause. And this is 1 out of 6 babies that dies. 1 out of 6 dies from the cause that we think is most preventable. And that's related to unsafe sleep practices. So what is SUIDS, or sudden unexpected death? It's the death of a baby at less than a year of age that occurs suddenly, unexpectedly, and whose cause of death is not immediately obvious before the investigation. It's really divided and coded into 3 categories. So what many people have heard of is SIDS, but it's really a diagnosis of exclusion, right? You don't go in and just look at a baby, say it's SIDS. It cannot be explained after there's been a complete investigation that includes death scene, review of the clinical history, a complete autopsy that includes toxicology, x-rays, pathology, and if indicated, genetic testing. So what are the other 2 categories? Well, I don't know what I did with them. Okay. The other 2 categories I'll go ahead and put up are unknown. And that's basically after they've done, so this is SIDS. The other is accidental suffocation and strangulation in bed. So basically things like the baby ended up with a blanket around their face or a pillow, or they were co-sleeping in a bed with the parent and the parent rolled over on them. So unknown basically means it wasn't this, and an incomplete workup for SIDS was done. Right? So somehow we didn't do the autopsy or the crime scene investigation or something where we're really not allowed to say, was it truly SIDS, which means we truly don't know why? Was it truly accidental suffocation and strangulation, or do we not know? And I want you to notice that this SIDS has continued to go down, but guess what's happened? The unknown causes have gone up. Frankly, we're just labeling them better. We're saying we don't know because we didn't do the full investigation that is required. And the accidental suffocation and strangulation in bed is going up. So overall, what we've seen over the years is a marked decrease with the Back to Sleep campaign, right? Then some leveling off, and then the Safe to Sleep campaign with some improvements there. And actually what we're seeing is this is ticking back up. We all still have a lot of work to do around safe sleep. This is Indiana's data. Again, it's been a pretty steady increase. So in 2016, the American Academy of Pediatrics used to only talk about SIDS, and what they recognize is that we really need to expand our recommendations to focus on all sleep environments. And I'm not going to read these to you. Most of you probably know them, but I'm going to put them up there just so you can review them. Remember this one with a 24% risk of SIDS? Some of these are interesting, again, associated with obtaining prenatal care, right? Immunizations. So, poster that we often see is the ABCs alone, not with other people. No pillows, nothing, no blankets, no stuffed animals, nothing in that bed with that baby. Not on their stomach or their side and in a crib. I always put this one up here because unfortunately, when I trained, we were told if babies spit up, if they have gastroesophageal reflux, you're supposed to put them up in a chair and let them sleep upright. And when you think about the anatomy, frankly, that just didn't make sense. So if you think of a baby spitting up, so it's coming up here, going up the esophagus and out the mouth. If the baby's on the back, right, and the emesis, the spit up pools, it's down here. The trachea is on top. But if the baby's on their stomach and the baby spits up, guess what gravity's going to do? Pull that spit up right into the trachea, right into the windpipe. Okay, so we were teaching the wrong thing. And I know a lot of, frankly, physicians still say the wrong thing. And it's one of my goals is to get people educated and up to date on things. So how are we doing in Indiana? The Child Fatality Review Team got medical records and death scene records and everything they could get to really review all infant deaths in Indiana. So these, even though the report only recently came out like last year, this is all from 2014 data because it took a long time to get all that data together. So they said that the SUIDS rate in Indiana, even though the official rate wasn't there, was 17%. So 1 out of 6, they missed some of them. And even though they couldn't categorically link unsafe sleep to the death, meaning they couldn't say it was accidental suffocation. In fact, 99 of the 105 deaths, infants was placed to sleep in an environment with at least one unsafe sleep factor. And 4 may have occurred in an unsafe sleep environment that wasn't documented, and only 2 of the 105 documented the presence of no unsafe sleep factors. So that's rare. When we look at the ages, typically what we hear is the age is between 2 months. The peak age is 2 to 4 months. So I always tell people, you know, the hospitals talk about safe sleep, but guess what? Is the baby still in the hospital at 2 to 4 months? Generally not. This is your problem. Right? This is the community's problem. What we see is disparities in this. So African Americans are about 10% of the population, but account for 26% of the SUIDS death. The caregiver at the time of the resident, the incident is 2/3 of the time the biologic parents. What that means, though, is 1 out of 3 times it's somebody else. So one of the things that you'll see in the other model we'll be introducing is a social ecologic model. How do you reach beyond the parents and think about safe sleep in your community? So there, 2/3 had a pack and play. They had a crib. Just having a crib is not going to be the answer. The problem with with having the crib is 50% were still in the adult bed at the time of the death. So only 26% were documented to be on their back. And I'm going to show this really busy slide, okay? But what I really want to show is not the details here, but there's 4 categories up here. No response, yes, no, and unknown. And really what this talks to is we need to do a better job of our death scene investigations, and we need to support that in our local communities, because there's too many times that we just don't know. All right, so the model that we think about when we're doing safe sleep work is really about the social ecologic model, which says that individuals cannot be considered separately from their social milieu and context. Programs incorporating multiple interventions extending beyond the individual level have the potential to be more successful. If you are only working with the mom, I would argue you're not doing enough. All right? You have to work not only with the individual, but those relationships around her, with her community. What are they doing in her church's nursery? Are they putting all the babies to sleep with blankets and on their stomach? What is her community saying about what is safe sleep? So there's a lot of data that would support using these extended models. Number one, modeling really helps. So if in the hospital we're modeling unsafe sleep behaviors with blankets and things, then parents are going to go, well, they do it there. Why can't I, right? Again, at 32 weeks gestation, babies are supposed to be flipped over onto their backs in the NICU. If they receive information from their doctor, they're more likely to put their babies on their back, but only about half of people actually get appropriate advice. This is the one I always love to talk about. If a grandma's in the house, guess what? Baby's 2 to 3 times more likely to sleep unsafely. Yeah. And receiving verbal recommendations works much better than anything written. If you're handing out brochures, basically, I would say you're wasting your time. All right? Need to have those conversations and problem solving. You're co-sleeping. Tell me about that. What's been working? What do you know about safe sleep? And then, again, there is a book that I think everybody gives out, like at the hospitals. And again, it works much better. I love the quote about this one is, how many people remember their favorite brochure from childhood? Okay. Yes. It's a children's book, right? It says Sleep Baby Safe and Snug. And the sad story behind it is it's actually a pulmonologist, critical care pulmonologist, pediatrician from Cincinnati Children's Hospital, who was on the couch with his infant son, and the baby died. And he said that should never happen to another parent. And what can I do? And they have a whole foundation and do these books. So it happens to many different people across different socioeconomic levels. And So again, kind of one of the things we did is to think about who are the people who support moms. So we've divided demographically into work groups to work within our community. So you guys need to think again beyond just working with moms and how you're going to extend those to the relationships in the communities that they live in. All right, let's talk a little bit about disparities. So infant mortality by race, African American and whites. Again, African American, 2 to 3 times higher infant mortality than whites. When you look at the sewage rate, we had this huge increase last year. It's down 40%, so it's down here this next year. I saw briefly the data. It isn't officially out for 2018, but we really have work to do in this area. So the black infant mortality rate has been more than double the white infant mortality rate for decades. It's interesting, though, that I said decades, right? Not 100 years. In fact, if you go back to the 1850s, the black infant mortality rate was only 1.5 times greater than the white. So is there something biologic, right? Why do African American moms or babies die? So there's been several studies, and this one is pretty sophisticated. I like this. What they did was actually study U.S.-born white moms, U.S.-born black moms, and African-born black mothers. So if you look at the infant mortality rates, and actually I'm sorry because they use low birth weight, it was easier to get than the infant mortality. But if you look at the birth weight, which is highly correlated with infant mortality, which ones do you expect to be more similar if there's a genetic basis for infant mortality? Yeah, so if this construct of quote-unquote race, then you might expect these to be more alike, right? So what do we find? In fact, the African-born moms and the white U.S. moms overlap almost exactly. It's the U.S.-born black mothers that have the lower birth rates. What's going on in the United States, right? What are we doing with our African-American population? It certainly does not look genetic. So, is it because there's factors associated with infant mortality? Is there a lot of more smoking or limited prenatal care or other things that account for this difference? So the reality is there are some differences. In fact, whites are more likely to smoke tobacco than blacks, right? We've already talked about unsafe sleep practices, however, are increased in the African American population. If, however, you control for these risk factors, right, in a statistical way, what we still see is that there is increased rate of infant mortality in African Americans. So it isn't just risk factors. Well, is it then that there's differences in what we consider protective factors? So, gosh, you can hardly see this. I am sorry. Didn't show up very well. Is that one? Oh, yeah. Why does it show up over there, not this one? That's funny. Okay. So I don't know if you guys can see this, but if you look at age, so are African American moms having babies at different ages that lend to higher infant mortality rates? Well, we know in whites that there's kind of a U-shaped curve here, right? So if you have babies really young or you have babies really old, your infant mortality rate is higher. So that is, age can be a protective factor if you have your babies between these ages. What happens in African American? Right? That's almost flat. There is no safe age, essentially, for African American women to have babies. It isn't because they're having them younger or they're having them older. What about education? Does this one show up over there too? All right. This is again in white. So we know that if you have less education, you're generally more likely to have infant mortality. And that gets better. As you become more educated, your infant mortality rate goes down. Is that protective factor there for African Americans? Actually, no. And in fact, one of the most interesting things is that women who are highly educated, African American with master's degrees and doctorates, actually have an increased infant mortality rate. So a lot of the biases and things that we think about, we need to rethink about because the protective and risk factors are different. So what may be different? Well, one of the things we know is that there's geographic disparity. So 29 of the zip codes account for, which are 3% of the zip codes, account for more than 1 out of 4 infant deaths, right? And these zip codes are primarily areas with people of color, right? It's the old areas where there was redlining, where we systematically put people into high-risk, high-crowded poverty areas as a country. And you'll notice that one of those is here in Allen County, 46806. This is a 5-year total. Okay, but basically 7 babies a year in one zip code die. Okay, how big is a zip code? You could walk it, right? You can walk across a zip code. It isn't that big. It's usually about a 4 mile by 4 mile distance. So people have asked, is zip code more important than genetic code in health and infant mortality? And you pull back and say, okay, what are the things that influence your health? So certainly 40%. Oops, I did this. So the things we typically think about is people's health behaviors. That woman should quit smoking. That woman should eat healthier. That woman should do all these things. And she should. But 10% is clinical care. We rely way too much. I'm a pediatrician by training. I'm part of this clinical care, but that is not going to be the answer long term to decrease our infant mortality. And then 10% is probably genes and biology. So this is where we generally focus our efforts, but that means we're forgetting 50% of what affects our health. And that includes social and economic factors and the physical environment. That one. All right, these two account for at least 50% of your health. So going back again to that perinatal periods of risk analysis, if we're going to make moms healthier to decrease the excess mortality, where do we need to start thinking more broadly in terms of what we do? So to make lasting change in health and outcomes, to address these geographic and racial disparities, we do need to work what's called downstream by providing clinical care. And I think we do a decent job of that in Indiana. We also need to address things midstream, which is really addressing individual social needs. So when you work one-on-one with that woman to help her eat healthy or to herself to stop smoking, that's very important for that one woman. But if you think about this in terms of high-risk geographic areas, once she has her baby, guess what? There's another woman right behind her, right? Have you made sustainable, lasting change? You're basically treating one woman at a time. And again, it's very important to treat that woman. But think beyond that into how are we really going to make sustainable, lasting change? So really to make that kind of change, you have to improve community conditions. And the model that is most often talked about in doing that is really social determinants of health. Okay? So a lot of people confuse social determinants of health with social needs. And I'm going to make this very clear that they are not the same. Social needs tend to be one individual at a time. If you're really addressing social determinants of health, it's defined by healthy people and the World Health Organization as the conditions in the environments, right? We went back and talked about what determines health. And part of it is that social and physical environment in which people live, learn, work, play, worship, and age. That affects a wide range of health functioning and quality of life outcomes. So this is a model. You generally think of 5 categories with social determinants of health that you need to address in order to make that sustainable change. So social and community resources, safety in the built environment, economic, educational, and healthcare. And again, these need to be changes at a system level, not just an individual level. So one of the things that we're doing, and if you want to hear more, I know that Staci would love to talk to you, and I could talk for hours about this. But basically, we are taking a different approach to address these social determinants of health with a variety of partners here being led by the Healthier Moms and Babies organization. And what we're doing is using childcare as a vehicle to address the social determinants of health to attack infant mortality. Okay? So how can we do that? Well, how are we addressing education? Well, early brain development, as I said at the very beginning, is one of my passions. And if we can get babies into safe, secure, nurturing environments, we're giving those children the best start possible. The other thing is to be licensed. You have to have a CDA for your people. So you have to have people, hopefully from the community and in the community, educated around child development. You're employing people and building a small business within that community if you can make it sustainable. So you're building within those high-risk zip codes economic development. The built environment, really, how do you build in safety? And Staci talked a little bit about how one of the things we're doing is really focusing on safe sleep and modeling that for families and giving them the resources so that they can have a safe environment at home, but also learn from the modeling of childcare that you really can do safe sleep and your baby will be great. Community resources, how can we link the moms? If you think again about moms not going for health care, where do moms go? Well, when they're working or going to school, they may need a safe place to put their baby. And who do you learn from, right? I can talk till I'm blue in the face about safe sleep, but guess what? Probably the person most trusted, if you're going to leave your baby with somebody, you probably trust them. And if your child care provider starts talking to you about a variety of things, like safe sleep, like nutrition, like child development and discipline, those are the people, frankly, that I learned from. They're well trusted and learned. And then, of course, health. What I like about this model is we're including that health model, right? We're including what is the 1 out of 6 causes of death of babies. We're doing the safe sleep, and what we hope to do is expand that as the program builds so that that families get connected with other people in the community like you all and other resources. So my conclusions, we use the social ecologic model as a framework to address the most preventable cause of infant mortality, which is unsafe sleep. We use the life course framework to recognize the need for not only pregnancy care, but also interconception care. And implicit is one model. And again, if you know any practices in Allen County that want to be part of that implicit model, I know that Dr. Scott would love to talk to you. And then to make sustainable reductions in racial and geographic disparities, we really have to move upstream to address conditions in the community. So we use the social determinants of health model. So again, I shared tons of data with you. What I really wanted to do is give you some other frameworks to really think about infant mortality in a new light and to expand on the great work and the assets that are already happening within your community. I'm pretty sure that's it.
Wow, thank you, Nancy. So we have time for questions and answers. So if anyone has a question, raise their hand. I will run across the room. Of course, it usually comes from over there. I'll start with the question because why are investigation rate so low or effectiveness so low?
Yeah, so it's a good question. It really stems from a variety of things. Historically, people would flat out tell you, like the coroners would say, I didn't want to tell that parent that they suffocated their baby. I mean, it's a hard conversation to have. Second of all, even though the State Department of Health has done a good job of training people in crime scene investigation, they just trained a whole bunch of people again about 2 years ago. People move on and things like that, and it's hard to get there. And again, to reenact the crime scene. And third, frankly, is the cost. Radiographs to do on a baby that's passed away, I don't quote me on the number, but I think it was something like $200, right? And so counties are like, are we really going to spend $200 on doing x-rays on that baby? So there's a variety of different reasons. I think, though, that if we really want to get to the crux of what's going on, we just need to make it a priority. Yes. Yeah, the question is who makes the decision of whether a full investigation happens basically if a baby under a year of age is found dead at home and there again isn't an immediately observable cause, that investigation should happen. And the police are called and also Child Protective Services is called. Yeah, that doesn't happen. Right. No. If the baby dies in a hospital, it isn't considered a sudden, unexpected infant death.
Just a quick question. Massachusetts is the most successful in this area. What have they done compared to, I guess, Indiana, since it's where we're at?
Yeah. So, number one, economically, they're much better off than Indiana. Number two, though, they've done some interesting things around providing health care for all of their population. So I don't know if many of you remember, but Romney Care, so Republican governor, helped pass legislation where every single person in Massachusetts was insured. So interconception care was a given, right, to anybody who wanted it. That's actually the ACA was modeled after Romney Care. People oftentimes forget that it was modeled after a Republican governor, but it's true. So one of the things we know, I mean, if you think about why, those geographic disparities make a big difference, and those areas of redlining make a big difference. And so what are the resources within those communities? It's a good question, and I don't honestly know, but I would guess yes, because I don't know any state that doesn't have them. I can find that out for you. I think one of the interesting things is the only place where I've seen they've actually flipped it, there's a model called Community Pathways Hub model in Ohio. It's an interesting model around home visitation, where there's a hub that collects data, does the contracting, and they actually have what a pay-for-performance model. In other words, so the home visitors get paid if the baby is born greater than 1,500 grams. And in some sense, that sounds terrible. In other sense, what it allows you to do is to do whatever you want to do with the payment to make sure that that mom is okay. If she needs housing, great. Let's go and work and get you housing. If she needs transportation, let's do that. So it allows them to build their own systems of support because they get a lump sum for the outcome, not for doing this many home visits or this much education or this much whatever. And in that county in Ohio, they had actually, it was a worse ratio. It was like 4 times the rate of African American babies dying. And that model now, I think, is 8 years old, and they've actually flipped it so the African American infant mortality rate is less.
Any other questions?
I'm trying to think the best way to word this, but what about, many of us in the room are always trying to figure out how we access these moms and connect with these moms. So how much of this, or what are some thinking around missing moms and getting folks engaged, or that's going through my brain?
I could have paid you to ask that question. that's my thing. That I really think that we need to do a better job of connecting with all moms. So one thing that helps, I think, is going into the high-risk zip codes. But we know from data and research that young moms are in these areas of high poverty, high crime, are among the most isolated people there are. And so I don't think we're doing a good job. I one of my pet peeves, sorry, because I hope I don't make anybody mad, but one of my pet peeves about home visiting programs is almost all of them, at least in Marion County, the woman has to show up for prenatal care and then she gets home visiting. Well, frankly, I'm not worried about the women who are showing up, right? It's exactly what you said. I'm worried about the women who aren't showing up. So I don't know that we have the right answer, but we're doing some things like looking at the social ecologic model and saying, where can we reach out? One of those places is actually within the churches. And do I think that these women are going to church? No, frankly, I don't. But guess what? their neighbor may be, their auntie may be. So if we can really empower people within the church, within that community, to think about and talk about infant mortality, then we might be able to link into their neighbor or whoever. I know that there's also people, we've done this isn't the right term, but it's basically community sweeps or outreach, where literally people go and knock on the door of every house in the community, and there's the fire department there, and they provide change the batteries on the smoke detectors, or we'll put in a smoke detector. The health department, actually, if you haven't had your flu shot, will give you a flu shot right there on your front stoop, right? And we actually go with those other community organizers to see if we can identify that there's any infants or pregnant women in the community and reach out to them.
Okay, thank you so much, Nancy.
I'm just going to add, I think you know why we think she's a special gem. Can we give her a round of applause for sharing that? Our next speaker, as you'll see on there, again, a very short introduction, is Erin Norton, who many of us in the room have had the privilege of working with locally. But Erin, as you all know, leads the Fetal Infant Mortality Review Task Force. And share with us what you're learning, please. You have the mic.
Hi, friends. Hello. So, who's feeling a little overwhelmed right now with all that information? Anybody? Am I the only one? Okay. Well, I have to follow speaking right after Dr. Swigonski, so I got a little added pressure there too. This is heavy stuff, right? It is literally people's lives, babies' lives, our most vulnerable, one of our most precious resources. It's a lot. It's winter right now, and it kind of feels cold and dreary, but I'm feeling optimistic, okay? I'm going to share some results. Some of them kind of feel like downers, but I feel really optimistic about it. So it's pre-spring. It is pre-spring today, okay? Forget the cold weather. Spring is on the horizon. So I'm going to share an overview of what FIMR is in the process, an example of a little success story that we've had, what we discovered, and then recommendations of some things that I think we can all do to make a difference. So FIMR is a two-tier process. The part I'm going to focus on more is the case review team right now. It's a multidisciplinary team. We get together and review individual cases of when a baby dies. These are Allen County babies. These are actual kiddos that are in our community. It is absolutely 100% local. So when we're looking at the national rates, Indiana rates, these are our friends and neighbors. These are our babies, our babies. All of the moms are offered maternal interviews. A little over 40% right now are accepting these interviews, and it's their choice. It's a big ask to talk to the moms, but it is really valuable because who is the expert on a woman's pregnancy? Who is the best expert? Who? Mom, right? She's the expert. And so whenever we can get her input, it really gives us a lot of excellent information. The cases are all de-identified. I'm the only one who knows. We get our the records from the health department, vital statistics. So we take out babies' names, doctors' names, dates, so we can really just focus on understanding what happened and also quality improvement. And so there's no, it's not a punitive process. There's no finger pointing. There's no calling anybody out. It's really a collaborative process to figure out how we can do better. And also see what we're doing right. There are some cases where we're like, oh, wow, the outcome was bad, but this mom was supported. There were a lot of things going on positively for this case. And then after we look at many cases, we tend to notice some trends. I'm going to report back on some of those trends and then give some recommendations today. The Community Action Team is the second tier. These are committees that design and implement interventions based on these recommendations. Individuals also can use these recommendations. I would absolutely encourage you to do that. In fact, I'm going to encourage everybody to, as individuals today, to do something new and different following or using some of these recommendations. So the Self-Care Toolkit is a collaborative project that our community worked on based upon needs that we discovered in our community. What we found were that a lot of women who had experienced the death of a baby had some mental health concerns going on. It's really hard to get up and go to a doctor's appointment when you're depressed. And we really felt like mental health was kind of a root cause of some of the other issues that were popping up. When our community, our collaborative group got together, and what we realized when we were looking at existing materials is that we didn't really find exactly what we wanted. Some of the materials were really heavy on the reading. We wanted something that was more bullet points. A lot of the pictures are white 30-year-old women. Not representative of our community. And actually, I've got a couple I want to show to you. Language barrier is also an issue. And so we have them both in English, and I didn't put it up there, but also Spanish as well. We considered a Burmese copy. But after talking to some of our Burmese community health workers and people in the Burmese community, we realized that maybe wasn't a culturally appropriate thing to do. Also, when we looked at self-care on websites and other areas, some of the recommendations were go get a mani-pedi, go to the movies, things that were cost prohibitive to most of our moms, right? Yeah. And so what we focused on were things that are zero cost. All of the recommendations in this self-care handout are things that any mom can do at any time. We've gotten a lot of really good responses. A lot of people are using them and really like them. It's a way that we can talk about mental health in a way that feels, in a way that we can reduce some of that stigma, normalize mental health, and give some moms some support. I would never recommend just giving this mom here, this is going to fix it, but it's part of a conversation, also talking to other resources. The last page lists different groups, other resources in the community where moms can go and get more mental health as well. So this is an example of, we noticed a trend, noticed a problem, noticed a trend, and we did something about it. So some of the things that we discovered, not all deaths are preventable. Unfortunately, there are some there are some genetic issues that we just don't have the scientific knowledge to correct. But there are things in many of these cases that we can do to ease pain and suffering for these families, and that shouldn't be discounted. For those deaths that our team thought were preventable, usually there were significantly more risk factors. On cases where we thought that the death probably wasn't preventable, it averaged about 3 risk factors from our list. On deaths that were preventable, there were about 8. So we have lots and lots of opportunities. We also realize that people and cases are complex. No surprise there, right? There's very rarely one specific thing. Oh, if this one thing would have happened, it would have made all the difference in the world. It's usually not like that. There are usually many, many factors. And we have the opportunity to improve the health and well-being of families in our community. But to make sustainable change, it's going to take all of us working together. So before we get started on some of the trends, I just want you to consider a couple things. When you're talking to a woman, what are her priorities? That's really important. Whatever is most important to her is probably what should be most important to you. Could you be the first person to detect a risk or a need? And what might the difference be between you acting on it then or waiting because maybe somebody else down the line? Maybe she's not even pregnant yet. Maybe it's a woman who may become pregnant in the future. How could her health and well-being be improved? Dr. Swigonski talked a lot about women's health. And so a lot of times when we talk about infant mortality, it's really a bait and switch, right? We have all cute pictures of babies, but it's really the maternal health. It's really mom that we need to focus our energy. So yeah, all the cute pictures of babies, but mom's where we need to focus in most cases. And what's something that you can do after you leave here today? I'd really want you to think about something that you can do to make a change, whether it be within your organization, you personally within your own personal sphere of influence, or if there's an idea where you think that you might be able to collaborate with another agency, I can help you make those connections. You make them on their own, but really, again, it's going to take all of us. I want you to think about if there's one little thing that maybe you can do, whether it's in that church nursery. Are you going to be in there on Sunday? Maybe it's you who can make sure you're taking all the blankets out of the cribs and then telling all the other workers why that's important to do. These little things may actually represent significant, much bigger change. So first, chronic maternal health issues contribute to poor outcomes. Over and over again, right? Those pre-existing conditions, diabetes, hypertension, depression. How can preconception health be improved? Is it smoking cessation, access to healthy foods, primary care? Make sure you're talking to women about these. And women don't necessarily have to be pregnant before you start these conversations. In fact, we really want to have these conversations before pregnancy, right? If I'm going to go on a road trip for 9 months, right? Before I get on the highway, I want my car to be in good condition, right? Like I want air in the tires, I want gas in the tank. I want it to be ready to go before I get halfway through my trip and everything kind of falls apart. Folic acid. You're gonna hear that a lot of this is repeating what Dr. Swigonski already has said. We are finding that very few women are taking a folic acid supplement prior to that initial prenatal visit. We really want them to take it before they're pregnant. Again, is it just a lack of awareness? Is it a lack of support? Whatever it is, this is something I think we all can work on together. Women are not accessing community resources. Again, the networking, when we went around and everybody said their name, that's part of it. So we know who to connect with, what resources are available. Again, the directory on here, great tool for our community. In Allen County, we are very fortunate that we have so many resources. Not every county, especially in some of these rural areas, don't have these resources. We do, but we need to make sure that women know about them and know that they're eligible for them. And then also including family members in the education and resources, right? Because it's not just the woman, right? We need to tell everybody about these things. If grandpa is living in the home and he's smoking, do we want him to quit smoking? Yes, we do. We want him to quit smoking also. Women lack social support. When I go out and I do some of these maternal interviews, this is really one of the hardest things to hear. When you talk to a woman and I'm asking about who was there for her during her pregnancy, who was a source of support, and she tells me about an aunt in Chicago who she really hasn't seen in a couple of years, and maybe there's an occasional text and then she changes the subject. That's her best source of social support. We can do better. And there are too many people in this county who care about women for that ever to be the case. Promoting home visiting, and then again, the OB Navigator program is working to help with that as well. Domestic violence. We really need to do better screening for domestic violence. There have been multiple times as we've looked through the cases examined where it's suspected. When we look at everything out in front of us, it's easy to pick up on things that maybe aren't detected in visits, but when you have the whole pregnancy and delivery and everything, you can see more of the picture. I would really encourage you when you're talking to women to please do the screening and please refer to resources. Sometimes at a doctor's appointment or in the hospital, that partner is there with her, and it is very difficult to complete the screening. And you don't know when you're working on her one-on-one, when is the next time somebody's going to get this woman alone to do the screening. So if you have that opportunity, do it. Mental health, talked about that with the self-care toolkits, promoting self-care and increasing screening. You can't tell that somebody is depressed by looking at them, right? You can't tell if somebody has anxiety by looking. You need to do the screening. And again, connecting women with resources. Social needs, got the social determinant of health model. You should recognize that as well. Unmet social needs. If a woman doesn't have housing, if she doesn't have food, she doesn't have reliable transportation, all of these things are affecting women in our community. We found that women are not compliant with plans of care if they can't afford it. No shock there, right? But what if the plan of care includes a $4 bottle of baby aspirin? And she can't afford that. We can't assume that we know what's affordable. We always need to ask. Dr. Google. If I have to hear about Dr. Google one more time in a maternal interview, I think my hair will turn gray. Oh, wait. So I really think that's an opportunity for us as a community to promote the use of appropriate websites, right? And also encouraging women to communicate with their providers and not solely going along what they find on the internet, despite if there was a really great little meme on Facebook about it, right? Not the best practice. So I'm putting on my lactation consultant hat here. It's not, you got to be very careful with websites too, right? If someone wants information about how to mix formula, the Similac website would probably have some pretty good information. If a woman wants information about breastfeeding, not a good place, right? Because the promise of Similac is that they promise that they want to make money, right? That's their business. That's what they do. So when we're talking about breastfeeding, feeding shouldn't be a frenzy. So the implication is there, it's going to be a frenzy. It's going to be challenging. It's going to be all these things. Maybe not the best place. Maybe not the best place for breastfeeding advice, right? But again, if you want to learn how to mix formula, sure. But just because you're referring a website to one person, it might not be appropriate for somebody else. Late or no prenatal care. It's rough. It's rough when we see these cases where a mom doesn't come in until the very end of her pregnancy or not at all, when we see her for the first time in labor and delivery. Increasing women's awareness about the importance of prenatal care, helping her break down any barriers to get to it, all super, super important. And we also want to help women understand the difference between pregnancy resources and prenatal care. So there are some really great things out in the community that's a pregnancy resource, right? But it's not prenatal care. So an ultrasound that's used as a bonding instrument to get mom to understand that her baby is alive inside her and that to promote that bonding is not the same as an ultrasound in the physician's office that really is, has a medical professor going through, one by one, all the things that's going on with that baby. Insurance. I was feeling a little snarky when I put up this graphic, sorry. I'm so glad we've got people like Amanda in this room today because insurance is tough. Insurance is hard. Worrying about payment is really a barrier to care. And we're finding that a lot of women, even if there's documentation that presumptive eligibility has been explained to them, they're still very hesitant because that fear of a medical bill is real. And so I think it's another one of these things where that consistent and persistent message is really important. And emergency Medicaid, this is a problem in our community where women who don't have Medicaid until it's time to deliver, they just aren't always getting the care they need. If you're worried that you're going to have to pay for this hospital bill, if you don't deliver when you go in, you might wait until delivery is pretty imminent. And if it's a preterm delivery, we just don't have enough time to take care of that mom and baby and even attempt to slow that labor. Unsafe sleep. Again, I think it would be great to have that consistent and persistent message out there. The lack of data is a big concern. And there is nothing I would like more than accurate, complete data set specifically for us here in Allen County. It is my dream. I think that would really help guide us onto what we need to focus on. So if you've got ideas and you want to talk, I'm your girl.
Questions?
This isn't like a total question, kind of more of a comment, but I just wanted to say that what we are seeing over and over and over again is that whether we're talking about safe sleep or we're talking about anything else that we're talking to our mothers consistently about, in that 1 to 2 months when mom is exhausted and can't see through the blindness fog of exhaustedness, that's when we're seeing the safe sleep practices fall off. That's when we're seeing all these things, the self-care, the taking the vitamins, all these wonderful, great things they may have started doing aren't happening. And I know everybody in this room sees that, but that's what we see the most consistently. And we are talking a lot in a lot of our conversations about how do you troubleshoot that when you feel like a zombie and you don't want to put baby back in the pack and play because they just won't stop crying. So what do you do? What are the things that you can do? What are the options that are available to you? What can you be looking for? All those types of things to support that mom in that moment. And then actually helping her create a plan for what she's going to do, just like anything else, when that baby's up at night and can't sleep. And obviously we have staff there 24/7. So we have a lot of things that our moms out in the community may not have, but we have to have these conversations pretty much with every single resident when they come home from the hospital. Otherwise, we're seeing the safe sleep, and that's actually a requirement of our program and something we even hold them accountable to because it's such a strong issue.
Yes, and you know what? Being a mom is hard, right? It is hard. And not everybody has 24/7 help, right? And social support. Identifying as early as we can who is going to be there for mom, who is going to help her, because I don't think you can't do it alone. You just can't. And so for these women who don't have anybody, we've got to find somebody to support them. And I think that's a challenge to all of us. How can we connect this woman? How can we? Nobody can do it alone. But you're right. That is, and we have a culture too that a lot of times mom is great. Right? But until baby's born, and then we focus on baby and mom's needs get pushed aside. We've got to reverse that. We've got to make sure that mom knows that she is just as important now after she's delivered than when before baby was born.
So I have a question. The moms that have had a fetal or infant loss, do their names come up again? Or are we looking at totally different people?
We have had repeat customers. We have, and I hate that. I hate it.
I just want to reiterate something that you said, that as a pregnancy resource center, which is what a Hope Center is, while we do the pregnancy test and we do the ultrasound, we push. Go to prenatal appointments because we are not your doctor. And so we just want to make sure that we walk alongside them to support them, but we are not their medical facility. And so we try to push that a lot. But we, like you said, are finding they have no one. And so that's why we set up an advocate to be with them so that there's somebody going through this with them up until the baby is at least 2 years old, and then we pass them on to somebody else. And so thank you for pointing that out.
And I know you do. And that's why I was looking at you when I was saying it. But it's something that we all have to, and the same goes for, at WIC. Okay, well, I went to the WIC office. Well, that's wonderful. We are so glad you went to the WIC office and got those resources and got the information and education. And you still need to do this. Yeah.
Hi. I know that we talked about churches being a great way to get information out. And I work at Associated Churches as the Director of Communications. So if you have an event or something going on and you'd like to share that with us to get out to the churches, please let me know. I have a card. If you come see me after this, I would be glad to help. we have over 150 churches that are involved with us. And not just churches, businesses or other organizations. So our newsletter probably gets out to about, I would say, 3,000 people.
Any other questions? Oh, Meg, right there.
So what are the resources available to women who have experienced a loss? And so I believe that there is a section in the resource directory.
Yeah, there is.
Right here.
That
There's
would probably section in our purple book.
Yeah.
We do have an online directory, but that's for healthcare. Prenatal infant care is still in paper. You can get that from the St. Joe Community Health Foundation. We'd be happy to give you any, but there is a bereavement. We call it, it's under bereavement, but what happens? Yeah.
Mm-hmm.
Support group for her mom who has experienced the loss and is now pregnant again and is fearful about another loss. So it's called PALS, Pregnancy After a Loss. So and that is in that resource book also that she talked about. They're from DuPont Hospital.
Any other?
So when you guys do these interviews, is transportation brought up a lot? Like if it wasn't like unknown cause, like it was something that could have been prevented, but these moms just don't have transportation?
Transportation is one of many access issues.
Yeah. Okay.
Yeah. Is it all the time? No, but some of the time, yeah. Mm-hmm. Along with insurance, along with, not realizing I was pregnant. There are many, but yes, transportation is.
Transportation seems to come up. I'm on the FIMR review board, especially if it's high risk or they require a lot of appointments. They can go to one or two and then it just slides off.
Yeah, there's a big difference between if you're going to an appointment once a month or 2 or 3 times a week. That's an increased need.
As I said in my introduction, we're studying postpartum depression right now and looking at that in the link to supportive communication. And one thing we have found regarding our participants is they don't reach out for support because of the little microaggressions they receive from society. So don't assume a mom is okay. Don't assume that she's superhuman. And I can't think of all the phrases right now that we have been told, but those are, well, you're a mom, you should be able to handle it. Oh, you should be breastfeeding. Never judge a mom for what she's doing in public. Ask her how you can help.
I think that's all the questions. Oh, I'm sorry.
I just wanted to make a comment about churches. My husband is a pastor. I'm a first lady. And churches do not have the resources. We would love to help. And so if you want to come into the churches, contact us and then bring your services to us. And then we can help you get those services into the community. But the people that's in the congregation do not have those skills and those abilities and those know-how. But if you come in, perhaps some of those people will volunteer to be part of your group, but we can't do it without you. So that's what I want to say.
I would just want everybody to please give a big thank you to Erin
and thank you for lunch. Parkview Health sponsored lunch, so thank you.
So as we're leaving, you want to give it?
Sorry.
No.
Don't leave without filling out your evaluation, if you would, please, because we need that information, and don't leave without a post.
Okay, we have ordered posters, so there's 1 or 2 for everybody in this room to take back to your offices. we really don't want to take them back there for you all. So they're at the doorways. Please take advantage of those as you're leaving. We do have a group that's meeting after this on safe sleep, working on building a community-wide curriculum. A lot of people have reached out to us. We're invited, but if you're interested in that and you haven't heard yet, you're welcome to stay afterwards and start for the beginning of that conversation. Again, Dr. Nancy, thank you for traveling. Erin, thank you guys for a lot of the work behind it. Laura has done a lot of work behind this as well, and Mark on the St. Joe team. So, and thank you, Parkview, for a delicious lunch.
Take posters because I have to wheel them back to the office.